So this case is a 36-year-old premenopausal woman with no significant past medical history. She's diagnosed with stage 2, so clinical T2N1 triple negative breast cancer, receives neoadjuvant therapy according to the Keynote 522 regimen, and unfortunately, her surgical pathology reveals residual invasive disease in both the breast and one axillary lymph node. Her germline testing is negative.
Okay, so Dr. Abudara, based on the um, extended a very nice review of the clinical trial for the post-adjuvant setting, would you consider enrolling this patient in one of the ADC trial, like for example the Ascento-5 or the Tropion-Bersto-3 or Trophus? And what are the key eligibility criteria and the characteristics of this case that will direction you to a study versus another one?
Yeah. I think this is a key candidate for a study like that in the post neoadjuvant setting. It's a young patient who received extensive neoadjuvant treatment, and this is carbotaxol, AC, and Pembro, and unfortunately has in residual disease. In terms of key eligibility criteria, typically across the board, these studies require residual disease in either the breast or the lymph nodes. And many of them do have that germline testing requirement where if patients do harbor a BRCA1 or 2 mutation, they may not be eligible for the study. As of right now, our standard of care is capecitabine with or without the adjuvant immunotherapy. And that's a really, you know, distressing option to share with patients to tell them, your disease is very highly resistant to chemotherapy, and my only option for you is to give you another oral chemotherapy. And so this is absolutely a patient I would screen for one of these studies. As far as selecting one of these studies, that's challenging. I think ultimately what it actually comes down to in practice is what study is available nearby, right? What study do you have open at your site? As of right now, there's no signal to suggest that one of these ADCs may be better than the other. The addition of immunotherapy on top of the ADC is going to be better than the other. So whatever we can offer them beyond capecitabine, I think is an important consideration.
Would the toxicity profile that the patient experienced during the neoadjuvant journey influence, for example, the choice on which type of ADC we are going to pick and if we are going to continue doing immunotherapy versus single agent ADC?
Yeah, I think that there's a few considerations here. First and foremost, many of us have a lot of experience with these ADCs, whether that be sacituzumab govitecan or Dato-DXd in the metastatic setting. But I definitely think, of course, our threshold for those toxicities is different in that curative intent setting where our kind of willingness to accept something like an ILD risk is a little different than in our metastatic patients. As far as the toxicity profile of any of these ADCs, in general, there's the question of course, cytopenias, and often that just means adding support. With regards to long-term toxicities coming out of a regimen like Keynote 522, neuropathy is always a consideration, but thankfully those don't seem to be primary toxicities related to these ADCs, so that's less of a concern. I think one thing that I also do wonder about, and I don't think there's a lot of data on, is for these younger patients thinking about ovarian preservation. There's not really a lot of data as far as GnRH agonists and what their role is in terms of preserving their ovarian function. And so that's always a very tough conversation to have with patients, younger patients going on these types of studies, is that I can't really promise or share data on the benefit or success rates of GnRH agonists with these ADCs. But those are certainly, I think, the main things I discuss with patients going into these studies.
I think it's going to be really important, for example, to dissect the toxicity profile of the post-adjuvant disease study and figure it out the different toxicity of the different ADC, and then maybe tailor the choice of the ADC based on on how they have previously tolerated the Keynote 522 regimen that we know very well is not one of the easiest chemotherapy regimen our patient received with with breast cancer. So definitely, I feel like the the safety profile of the different ADC can be um, targeted based on the tox profile and immunotherapy as well may be dropped, for example, in patients that did not tolerate immunotherapy or had like special interest side effects associated to immunotherapy. Now, assuming that we are seeing the patient actually at the diagnosis, so before the neoadjuvant regimen was prescribed, what are the characteristics of the patient that will actually make you choose to prefer a neoadjuvant ADC approach versus, for example, the Keynote 522 regimen? And now we have seen the final data just recently and very well established.
Do you mean selecting Keynote at all or
In
neoadjuvant ADC?
Correct. Like, how do we select? Like, what are the characteristics will make you select an ADC neoadjuvantly
Yeah.
rather than the Keynote 522 regimen?
Absolutely. So, I think that we have some studies evaluating this whole idea of chemotherapy de-escalation in the absence even of an ADC, right? So there's the NeoPact studies and things of that nature, which have demonstrated that perhaps patients with smaller tumors, perhaps some node involvement, not too heavy on the nodal involvement, high stromal tills, certain kind of characteristics pathologically that encourage thinking about a de-escalated regimen already, perhaps an anthracycline free regimen. I think those are patients perhaps just as a clinician I would feel more comfortable exploring that de-escalated ADC in the neoadjuvant setting. um, I guess this is partly kind of dependent on the way protocols are written. I do like that adaptive radiographic monitoring involved. And so that gives me comfort if I'm looking at a neoadjuvant ADC study that has radiographic assessments folded in, gives me a little bit more comfort. And I think gives the patients a little more comfort when they're kind of embarking on an entirely experimental neoadjuvant type study. Um, Anything that you would consider when you're thinking about enrolling these patients in these ADC studies?
Yeah, I think you bring up two different points that are very important. One could be, for example, the stage of disease, and in a patient that is, for example, a stage two, so with the limited nodal burden, something that we are thinking about de-escalating strategy would probably be a better candidate for a de-escalation strategy with a single agent ADC. And the other one could be in patients that are more frail, so elderly, that we don't know and we don't feel confident about how they are going to handle the Keynote 522 or the NeoPact regimen. Maybe a de-escalation strategy with a single agent ADC sometimes could be the preferred option. I feel it is going to be important to consider also the event-free survival, because so far we have only seen the pathologic complete response rate. And again, while in triple negative breast cancer, as for HER2 positive, the PAT-CR is an excellent surrogate endpoint. I do think that with the single agent ADC, a look at the event-free survival and prolonged follow-up would be important overall to um, implement those strategy in our clinical practice. And then, Dr. Abudara, how would you potentially look at the long-term toxicity, specifically of the ADC versus the Keynote 522, and how do you factor that in the discussion with the patient on like which strategy do you prefer and like which ADC do you prefer?
Yeah, I think, when we're thinking about what are the most common toxicities that may carry over from one treatment paradigm to the next. Hematologic toxicities are always going to be the most prevalent, I think, and we certainly see much more of a dive with sacituzumab, for example, especially in that post neoadjuvant setting when patients have already been exposed to kind of multiple cycles of cytotoxic chemotherapy. That's always kind of a really, I think, pivotal part of the discussion for patients and preparing them for that need for GCSF support. I think another thing transitioning from that keynote 522 into the ADCs for adjuvant setting is GI toxicities. And we know that that's particularly SN38 mediated, especially with drugs like sacituzumab govitecan. And I think that calls into question kind of what kind of genetic testing we're also doing prior to assess their tolerability of that agent. And especially in our younger patients, but within all of our patients, I think early intervention is key no matter which path we take. So thinking about things like early intervention with loperamide and discussing with patients kind of more of an anticipatory approach as opposed to a reactive approach when it comes to these risks. And finally, I think when it comes to just that overarching ILD risk, it's just so important to provide that patient education to be aware of what to look out for. Sometimes, it's something as simple as a lingering dry cough for several weeks, but if a patient doesn't express that to us, it can really have quite devastating consequences. I think one thing when thinking about the whole chemo ADC IO debate as well is, we've seen some data from our colleagues in melanoma and thoracic about what this means for patients with pre-existing autoimmune conditions. Again, it's a little bit of unknown territory when it comes to ADCs, but certainly that's always a consideration, right? If I can offer a patient an IO-free regimen that's just as good, I think that matters, particularly for our patients with conditions like Crohn's disease, lupus, and such.
And this, as a final note, let's keep talking about de-escalating. Let's assume that this patient is actually has a germline BRCA1/2 testing that is positive.
Yeah.
When would you consider actually offering a completely chemo-free regimen with the PARP inhibitor plus an immunocheckpoint inhibitor?
In the neoadjuvant setting or?
Correct. In the neoadjuvant
Yeah.
setting.
So, there was that data that came out of MD Anderson, NeoTALA, that looked at just single agent talazoparib in the neoadjuvant setting. I think it was something like 24 weeks of neoadjuvant PARP inhibitor. And the path CR rates were about 43% or so, incredibly encouraging to think about a completely chemo-free, a pill, to think about sitting a patient down and saying, you're going to take a pill for 24 weeks and then we can go to surgery is, I think, going to be a huge shift for patients, hopefully. And I think we've seen that potential combination with immunotherapy may even augment that path CR rate. So very excited to see how that story evolves. And I hope that we continue to dive into that potential. I think what's also interesting is that ADC data is particularly Ascento-3, where they saw a signal for improved response rates in BRCA mutated patients with sacituzumab govitecan. And while we don't fully understand why that is, I think we may be faced one day with kind of that decision point in the post neoadjuvant residual disease setting where we're thinking, do I give a PARP inhibitor? Do I give an ADC? Do I give the combination? I think there's a lot of exciting things in the pipeline for germline BRCA patients because of that unique biology.
Definitely. I think it's a very exciting moment for early breast triple negative. And with the advent of ADCs and immunotherapy, I think it's very nice option for our patients.